Hello, Mansa. Hello. Hello, Mansa.
Hello. Hello. Hello, sir. Can you hear me? Hello.
Hello, Manasi.
Yeah.
Yes, sir. Good morning, sir.
Good morning. Good morning. How are you?
I'm good, sir. How are you, sir? Happy New Year.
I'm good. Happy New Year to you. Happy New Year. Happy New Year. So
Subhash.
has Madhu sir has joined. Oh, hi. Hi, sir.
Okay.
Sir, you can start. Don't worry about others.
Okay.
We can discuss.
Okay. Shall we start now?
Sir, I have just opened the room. So if we can wait a couple of minutes, we can allow the students to trickle in.
Okay.
Okay. Right. Good morning, Umar. Subhash, shall I start?
I think so.
Yeah. So
There are already about 20 or 30 people. That is good enough. Then people will come.
okay.
Yeah.
So good morning, everybody. Just like our last session, we are doing the same pattern. This 13th session on challenging case series. The pattern is all same. I'm projecting case videos and asking question in between. So anyone you want clarification in between, you can unmute yourself or raise your hand. Mansi will unmute you. You can speak. So I am now starting to start sharing my screen. Can you see my slides?
Yes, sir.
Okay, right. Now we'll go to the first case. First case is always a short case. This is a 38-year-old person who is a known case of migraine, has presented with a different type of headache for the last 3 months. The headache was diffuse, mainly bifrontal, present continuously throughout the day. No vomiting, no nocturnal aggravation. He has no other complaint apart from the headache. Examination, there was no papilledema. Rest of the examination was normal. So obviously, it's a late on CDH of short duration, 3 months requiring investigation. So MRI was done in this patient. The MRI showed this finding. This is a T2 weighted sequence showing hyperintensity in the caudate, thalamus, mainly the putamen and lentiform nucleus, mainly the putamen. And in the external capsule, there is more hyperintensity than the rest of the thing. And the external capsule also the claustrum is also showing hyperintensity. Now I'll go to the next sequence. This is the next one. This is the uppercut. We don't not show much of abnormality. This is the flyer which sequence shows us almost same finding. The hyperintensity is seen subjacent to the insula, mainly confined to the caudate, thalami, lentiform nucleus, external capsule, and the claustrum. And this is another cut showing the same pattern. This is the coronal cut again showing that abnormality. This the diffusion did not show any diffusion restriction. T1 weighted shows only hypointensity in the same area. There is no contrast enhancement in the abnormality detected. Now, what do you think is the likely possibility in this patient? Anyone can answer or unmute and speak. Nobody? Okay. Mansi, you can unmute anyone you want raising their hand.
Madhu, he did not have any extrapyramidal signs or anything, nothing?
Absolutely nothing. Only headache. That's the complaint by which he has come.
And this headache is since how long?
This for 3 months. Headache is for 3 months.
And before that, he never had any history of headache or seizures or anything?
No. Before that, he had classical history of migraine. Episodic classical migraine.
Mitochondrial, sir?
Pardon? Mitochondrial. Okay.
Mitochondrial.
But, okay. Let us see. What finding was he's got a symmetrical abnormality. Whatever abnormality you found was symmetrical. Whenever a symmetrical abnormality in the MRI, one should think of some neurometabolic process, maybe mitochondrial disease, or osmotic dysmyelination, or ADAM, or viral encephalitis like gait. So these things which hypoxia all can cause this kind of an abnormality. Toxins like methanol poisoning can all cause. So, but there is no finding in this patient. Only complaint was headache. So naturally, we have to think some, mitochondrial, other ADAM sensibilities, etc. is unlikely in a period of 3 months duration. So I thought of some kind of a toxic condition. That's one possibility I had kept in mind. And this sign, I don't know what to call that thing. I termed as sandwich sign because it's something like a hyperintensity between two less hyperintense thing. I don't know if I'm correct or wrong. This is the only term I called it. But there was a clue in the history. He works in a battery factory where the battery cases were made. Any thoughts? Any thoughts?
Manganese or something?
Okay. So I thought lead poisoning because the lead is the one which is usually used in battery terminals and all. So I look for the blue gum. There is no blue line in the gum, but then you say it's got a blue teeth instead. Okay. His lead level was 56.32, the normal is 0.9, very high level of lead. The urine copper, sorry, on copper, urine lead also shows very high lead excretion. So in fact, he had lead poisoning causing headache, and this was the MRI appearance. No, in fact, I did not know such MRI finding can occur in lead poisoning. As such literature, I found that there is another case presented like this, which is the again showing the blue lines in the gum, and the MRI showing same exactly the similar appearance. This is not my case; this is a previous case report from the literature. Something like a sandwich between hyperintensity between two less hyperintensity area in the lentiform and the external capsule. Sorry, in the claustrum. So this is from the literature again. So this is a case of a lead poisoning producing this kind of an MRI appearance. He improved. We did not do anything. We just asked him to leave the profession and remain away from that. His headache gradually subsided. And but I took an MRI after 3 months. Again, the findings remain the same. Okay, shall I go to the next case? Any
But
comment?
what happened to headache, Madhu?
Headache improved. Headache totally improved over a period of time. 2-3 weeks time.
Okay, fantastic, fantastic, very good.
Okay, then I go to another case. Now comes the real cases. This 70-year-old diabetic patient who is a hypertensive individual was noticed as squint by the relatives and brought for consultation. Squint for the last 3 days. There is no diplopia. In fact, there is a past history. He had a right hemiparesis 4 years back, from which he totally improved. 1 year back, he developed left hemiplegia, from which also is improved but partially. He still has left hemiparesis, but that's not the complaint by which he came. But along with this history of squint, there was no history of any worsening of the weakness which was present earlier. So the present complaint is only squint, no headache, no other complaint, no pain in the eye. So this is the finding on examination. Look carefully for the ocular finding, ocular movement. So I'm asked him to look to the left side, looking to the right, and asked him to look up, asked him to look up again, then ask him to look to the left side now. Now looking down, looking down. Looking up again. Then ask him to look into the left side again, and then to the right side. He's got left human facial palsy and left hemiparesis, maybe part of the older thing. So if anyone want to see the video once again, I can show once again. Anyone would like to see the video?
Yes.
Yeah, I will show once again. But anyway, I've taken the clip photos to show you the abnormality later on. Anyway, asking the patient to the left side, to the right, looking up. You did not look again, looking up. I'm trying maximum look up. Keep on looking up. Now bringing down. Looking up again. Then looking to the left side. Now looking to the right side. So on examination here, in fact, I did not show you, he's got a cataract on the left eye. Extraocular movements, yes, restriction of the adduction on the right side, restriction of elevation of left eye, or elevation or restriction of both eyes more on the left side, and restriction of left eye adduction. But before that, I think I'll ask any one of you want to make a comment about the ocular movement. Where do you think is the site of lesion?
What about Bell's phenomenon and closed eye closure or doll's eye movement?
Dorsal eye movement, in fact, it's not indicated because he's got an extraocular muscle paralysis. Because dorsal eye movement we do when you suspect whether it's a element or Yeoman palsy or gaze palsy or element. So dorsal eye was not indicated. It's a clearly asymmetrical movement disorder. Okay, anyone? Then shall I go proceed, or anyone want to make diagnosis here? Is it myasthenia or is it
Upkiss is
but it can't call upcase because the asymmetrical restriction is elevated. I'll show the finding one second. I'll show. This is patient is looking to the left side. So what do you find? Obviously, he has got right adduction failure. Okay. Restriction of adduction to the right side. So that is one finding. Now the looking patient is asked to look up. Here both eyes are not going up. Or you can say left eye is at least not going up because that is lower compared to the right. So here we can say yes, got elevation on the left side is restricted, or both eyes are restricted more on the left side. Because regarding right eye, one cannot comment because as age advances, one can have a restriction of upkeys even other ways. So whether the lack of restriction on the right side is part of the age, we do not know. But apparently it looks like, but it's absolutely no movement upward. So most likely he has got upward restriction of both eyes, which is more on the left side. So when it's asymmetrically present like that, you don't call it as a gaze palsy. Gaze palsy should be symmetrical. If you find such a finding, you have to think that one muscle is more affected than the other, element paralysis. So this is the find restriction of elevation left eye or both eyes, more on the left side. And on looking to the right side, it is seen it's asymmetry on the he has got adduction in the left side. Okay, do you agree with that?
Yes, sir.
Yeah, mild restriction. So these are the findings. So findings: right adduction failure, elevation restricted, little more on the left side. Left adduction is also apparently failure is there. So where is the localization? Anyone?
What about elevation, the abducted and adducted position?
That there are the elevation is restricted in all direct elevation is restricted, but not specifically up and out or left up and out. On looking up, the restriction is there in all, whether it's abducted or adducted.
But Madhu, when he's looking towards the right side, do you notice that there's any change in the palpebral fissure? Is there any narrowing of palpebral fissure or no?
No, it was not there. It was not there.
With a neuromuscular junction.
Yeah, when you get multiple bilateral involvement, you got to suspect a neuromuscular, which is not fitting with it, cranial involvement. You are perfectly right. That's one possibility we have to keep in mind. So the other possibility is a bilateral partial third nerve, or is neuromuscular junction problem, or only right third nerve palsy.
Bilateral third nerve.
Background is that he was an old person, he had multiple strokes, now come with only short duration. Okay, I thought of right nuclear third nerve palsy. Now you may ask, this can explain, I'll tell you why I thought so. This can explain the failure of adduction of the right eye, obviously mid rectus palsy, and restriction of both eyes, because as you know that nuclear third nerve palsy supplies the contralateral superior rectus. So the opposite superior rectus is more affected here, as the left superior is more affected. Not only that, right eye also restriction is elevated because, as you know, the left superior rectus nucleus send across to the opposite side and go through the right or contralateral superior rectus nucleus. So what happens in nuclear third nerve palsy can have only contralateral superior rectus weakness or bilateral superior rectus weakness. It will be more on the contracting side. With this, you know, nuclear third nerve palsy. The same side suprarectus weak, not because of the nucleus is affected, but the fibers of the opposite happens to pass through that nucleus. So that can explain everything. Okay, except one. How to explain the adduction failure? See, this part is the one which you can't explain, right? How can a right third nerve palsy produce adduction failure on the left side? Now, this is what is called, this I, in fact, 2-3 weeks back on one lecture, I had told about this particular abnormality, which you find extraocular muscle paralysis, called inhibitional palsy. I'll tell you what is inhibitional palsy. See, in this patient, you know, he has got a right middle rectus paralysis, okay, due to element paralysis. When the right middle rectus is paralyzed, the antagonist of the middle rectus, that is the right lateral rectus, is overacting. Okay, when one is paralyzed, the other fellow will overact. So, or putting it other words, the right lateral rectus is an advantage in producing an abduction of the right eye. Agreed? Because it need to have only less innervation to produce abduction on the right eye because the antagonist is paralyzed. The medial rectus is paralyzed. So it is easy for the right lateral rectus to produce abduction. So when the patient is looking to the right side, less innervation is required for the right lateral rectus for looking at a target to the right. Agreed? According to the Herring's law of equal innervation, the same input goes to the medial rectus. Right? Because initially, if 10 impulses are required for the right lateral rectus, now only 8 impulses is required. The brain gives only the 8 impulses to the left medial rectus, the corresponding yoke muscle for the right lateral rectus. So what happened? The left medial rectus is underacting and appears weak. It appears weak. Actually, it's not weak. It's weak. And this is what is called the inhibitional palsy. This can be seen not only medial rectus, but also lateral rectus, rectus, all muscle. The yoke muscle may appear apparently weak because of this phenomenon. Now, how to solve the issue? We want to find out whether it is really a medial rectus weakness or inhibitional palsy is present. What will you do?
Close the right eye.
Close for
Yeah, exactly. Adduction movement. You close your right eye and look for the adduction to be normal. It was inhibitional palsy. In fact, I did not do that. Even without that, in the same video itself, you can see that patient is adducting fully well sometimes. When he puts effort, he adducts. You can see this adduction now. It is almost full now. It was not like previously. So that means what he had was actually inhibitional palsy. So the likely diagnostic etiology for the diplopia, or the squint is the nuclear third nerve palsy.
What about the pupil, sir?
Pupil is unaffected. Usually in the nuclear third nerve palsy, the pupil is spared. Only rarely it is affected. If it is affected, it is to be bilateral because there is only one parasympathetic nucleus. And usually, classically, this rule called Manganese rule, which says that in nuclear palsy, pupil is almost always spared. Okay. Now, coming to that's not solved the issue. We found that this is affected, but we have to prove it by what is the cause of this thing. Likely to be infarct.
Yes.
Yeah. But only third nucleus is affected. No first weakness, nothing. So, what do you want? MRI. Okay.
Medial rectus won't be affected. Medial rectus alone won't be affected.
Pardon?
In nuclear third nerve palsy, we say medial rectus won't be affected or medial rectus alone won't be affected.
No. Medial rectus can be. What I'm trying to say is that
Pupil.
The pupil will not be affected in nuclear third nerve palsy. And if it is affected by any means, it should be bilateral affection. Because there is only one Edinger-Westphalian nucleus which suffers both pupils.
Is there a rule where they say if it's a nuclear third nerve palsy, medial rectus alone won't be affected?
That depends. The nuclei in the third nerve is a complex. Or subnuclei are there. It need not be total. It can be partial. But it always can be partial. Moreover, what the rule I was trying to say is that nuclear third nerve palsy most of the time spares the pupil. One person has given a rule called Mothner. He gave that particular rule. Okay, am I audible to you clearly?
Yes, sir.
Yes.
Okay. Now, what do you want? MRI?
Contrast.
Okay, MRI also the MRI. This is the diffusion film. This is the medulla. This left side is the pons, right? Lower midbrain. This is upper midbrain. And there is infarct in the right thalamus. Small infarct in the right thalamus. And one more uppercut shows there is another small infarct in the periventricular region adjoining the atrium of the lateral ventricle. This is the flare sequence, which shows the atrophy of the crus cerebri on the right side, probably due to the Valerian degeneration due to the old right hemispherical lesion producing left hemisphere, which has happened 1 year back. So this is again the flare sequence uppercut. Small microvascular changes, some infarct, chronic infarcts are also there. So this is the finding now. So what do you think? There is no lesion seen in the midbrain to account for the nuclear third nerve or other process here.
Could be a neuromuscular junction then.
You want to do neurostic pin test. Okay, no, I did something else. I went back to the radio and said, no, I'm very strongly suspecting it. And you do the coronal cut. Always in brainstem lesion, the small infarct will be missed in axial. So always you have to do coronal cut. So this is a coronal sequence which shows the thalamic lesion, old one which will not explain it. This is the other infarct of the corona radiata. So look at this picture. It's going through the midbrain. He has gotten exactly in the nucleus, small infarct of the nucleus of the right side. That's a nuclear third nerve producing it. Sometimes infarct can sometimes be restricted to nucleus. I've seen other patients only patient nucleus getting involved. Another getting in the 12th nerve nucleus getting involved. These are all very rare, very, very rare. When you suspect intraaxial lesion, you would like to take a long-term science. But the background of the patient, we had multiple strokes in the past, and only being a short duration without any other finding. That's the way I thought. That's why we thought the possibility of ischemia in fact. So I pursued with that. I found picked up this infarct. Unless we do the coronal cut, we would have missed this particular lesion. So that's the story of this patient.
So what I was trying to say was isolated medial rectus palsy without other muscle involvement cannot be a nuclear third nerve palsy.
So it can be third nerve palsy.
No, isolated.
Yeah.
Medial rectus has got 3 subnuclei. So an isolated medial rectus palsy cannot be a nuclear third nerve palsy.
No, not right. You can have a medial rectus alone as a part of nuclear third nerve palsy. Or any subnucleus alone can be affected. It is not a must.
No, so this here because it has got 3 different locations, is subnuclei. So isolated medial rectus cannot be a nuclear third nerve. That's what I mean. It's already there in the given in the chat.
Yeah, here of course, not only medial rectus.
Yeah, here it's combined. So
combined is. So any other questions in this case? Subhash, any comment you would like to make?
I was just looking at the MRI.
Yeah.
There was a infarct which you showed lacunar infarct, but there was another lacunar infarct also at the top.
Correct. Yeah, yes,
so this is one more phenomena which I see sometimes, that the patient has, normally traditional teaching is that there will be one lacunar infarct, but many times you have more than one lacunar infarct simultaneously occurring. And it is very intriguing that how that can happen, but it happens. Yesterday also saw a patient, one of which is symptomatic, other may be asymptomatic.
Correct, exactly like this. Exactly.
And Madhu, one more question, just an opportunity to ask you.
Yeah.
When we check these eye movements, we look at horizontally, vertically. Now about vertical, we know that with age, particularly the up gaze gets restriction. What about the horizontal gaze? Is it necessary that the eyeball has to completely cover the sclera and be at the extreme, or there can be some normal physiological limitation without any disease? I just wanted to know.
Yeah, I'll answer the question. So what we look for in lateral movement is not whether sclera is visible or not, whether the eyes are conjugately moving to equal degree or not. What I meant to say is that suppose, imagine you have got exophthalmos. With good lateral actus function, sclera will be still visible. Okay, suppose you have got some people got a sunken eyes have gone inside, ophthalmos like picture. Even with restricted movement, you may feel there's a full attraction. So it is not at all ideal to look for the visibility of the sclera as evidence of restriction of either medial rectus or the lateral. So when you do the version movement, look for always the conjugacy of the movement. This can be tested by the eye vision or by shining a torch to find out when the light reflex is falling on exactly in the center of the pupil, whichever direction you take the eye into the different positions of gaze. Only you can make it out. The other way
if there's a normal conjugate movement, and even if a little bit of extreme sclera is on both sides, it's spared. It is a left. It may be okay.
Okay, it may be okay.
But it should not be asymmetrical.
It not be asymmetrical.
Yeah.
Suppose you are still doubt about another bedside test which you can do if you have got doubt. Suppose you have got lateral sclera is visible. You're not very sure about whether it's mild asymmetry, disconjugation is not. It's not possible for all sorts. First thing will you do the cover and cover test.
Okay.
You ask
Thank
the
you, sir.
in that position and cover one eye.
Thank you.
Cover, so you can find out the movement.
Thank you, Madhu.
Thank you. So, shall I go to the next case? Any more questions?
Yeah, sir, these patients, why they don't have diplopia?
Because he had a cataract on the opposite side. Your question is very, very valid. You should have present diplopia because on examination, he never complained of a cataract. On examination, he had a dense cataract on the left side. That is why he did not comment. Your question is very logical. I expected diplopia.
Okay, thank you.
Any more questions? Please ask questions. No, that may give me an opportunity to tell me to learn also. So, but shall I go to the next case?
Yes, sir, please.
Now, I'm going to show two videos of tremors from involuntary movement. Tell me what is this case. This man came with a history of tremorlessness movement on the right hand, especially by eating for the last 3 years. No other complaint. Is no postural tremor. And ask him to hold the hand like that. The tremor appears. It is a rhythmic movement, not like intentional micronas. Keeping it again, the tremor appears in that position. There's no rest tremor. There's no finger nose incoordination or intention tremor. That position it comes.
Looks like a unilateral wing beating tremor.
Okay. Right. Any other thoughts?
Red nucleus.
Red nucleus tremor. Okay. Let us say come to that diagnosis. So the postural tremor, action tremor, intention tremor, or task specific tremor. Anyway, somebody said the wing beating tremor. Joy said that. Any other possibility you'd like to keep in mind? Okay, I'll show you another case. This lady came with a history that whenever she uses cell phone with the right hand, the phone repeatedly hits her right ear and she could not complete her conversation. This complaint has been there for the last 1 year. I'll show the video of this lady. There is no postural tremor as you can see. There's no rest tremor. Yes, no, the position which I held earlier, there was no tremor in that particular position. There was no finger nose incoordination. Now let us see what is happening. She's asked to use her cell phone Keep the hand in that position, the tremor appears.
That a dystonic tremor?
Okay, dystonic tremor is not possible because of causing that. But there is no element of dystonia at all in this patient, even after that. They had the whole hand like that. There is no tremor.
So it's a task
More
specific tremor.
task specific.
Yeah, task specific. But it could be task specific tremor, agree. Right? Now let's see. But the lady's tremor is present even when she is bringing the hand in the same position without using the cell phone. Even without doing the same task.
The posture specific tremor.
Yeah, this is what is called not posture specific, positional tremor. Positional tremors arise when a tremor is brought on during specific positioning of the involved body part. This has to be distinguished from one postural tremor, wherein the tremor is elicited in any posture, or task-specific tremor, wherein the tremor occurs only during a particular certain task. So what the caveats is, the postural tremor may be present in. Caveat is that the postural tremor may be present in one position, in one position more than the other position, but it will be there in other postures. But in positional tremor, only when the hand goes into particular position, the tremor occurs. Likewise, the other caveat is that the positional tremors may present themselves during any specific task, such as putting a makeup, like our patient. However, the patient in positional tremor can induce the tremor by putting their body part in the associated position without actually performing the task. That is the point by which you can differentiate a task-specific tremor from that of a positional tremor. Without any task itself, the patient goes to that particular position that the tremor will occur as in our lady. If you remove the mobile phone, again keeping the hand in the same position, the hand will go on tapping on it. Task-specific tremors are defined as occurring primarily during a specific task and may be present in lesser degree during other uses of the hand. Positional tremors, by contrast, are present with equal intensity during any task that involves that particular position. Now, some of the so-called primary writing tremors which we come across may be actually positional tremors, because how to differentiate is, if it's due to the positional tremor, before asking the patient to take the pen and write, ask the patient to hold the hand in the writing position. For example, during the pronation, the tremor appears at that position. Without holding the pen, it is likely to be more like a positional tremor than a primary writing. So these are two cases of, both are benign conditions of what you call positional tremors, but treatment is too difficult. I don't know how to treat. I put the patient on Indra and Mysore, thinking there could be variant of pain essential tremor. Did not produce much of an improvement, only partial improvement. What literature indicates is that you give Botox injection to that muscle, which I have not done in this case. I do not know about Botox. So any questions on this case?
Sir, you mentioned about primary writing tremor, no?
Yeah. Correct. Yeah.
Sir, one patient has come to know when he sits and writes, he gets tremor and unable to write properly. But when he stands and writes, he doesn't have a problem.
Okay. So that case, you have to always primary, one of the DDA primary with the dystonic tremor, where if the writing difficulty varies with your position of the body, always think of a dystonic element, dystonic tremor. So in that patient, you have carefully look for any finger going into abnormal dystonic positioning while writing. If that's it. In the case of primary writing tremor, it should be occurring in whatever position the patient is.
Okay.
Any questions? This, according to the new classification, this positioning tremor has come initially classified as rest tremor, and postural tremor, and kinetic tremor. And the kinetic, under the kinetic tremor category, simple kinetic tremor, this positional tremor has come. So, shall I go to the next case? No comments, I can go to the next case.
And then static tremor, sir.
Pardon?
Static tremor,
No.
in which category it will be?
Static means it's a rest tremor. No? Static tremor in the patient is at repose, at keeping the hand at rest, it's a rest tremor. You see in Parkinson's disease or advanced BET. That's good. I don't know static tremor. That term is
Sorry, the orthostatic tremor. We had a patient.
orthostatic. Yeah, that's very, very common. That's very common. They can be orthostatic. What I find that more than orthostatic tremor is orthostatic myoclonus is more common. So whatever tremor, orthostatic tremor, except one or two cases, most of them have got the frequency is much less than what you find classically described in the 14 hertz in the orthostatic tremor. And there's a continuum. Some people have orthostatic tremor, some have orthostatic myoclonus. Both of them behave the same way. Since 2-3 weeks back, I had shown 2 cases of orthostatic myoclonus. One on prolonged standing and walking, someone bending down, all this kind of.
So we have got
why they are responding to clonazepam.
That orthostatic tremor and myoclonus, they respond very well to clonazepam. Both the patients respond very well. Okay. Shall I go to the next case?
Yes, sir.
Yeah, right. This 45-year-old man was referred by an ophthalmologist because I am choosing 2-3 eye problem because Joy wanted me to present eye problems. And eye malfunction in one case. Ophthalmic ruled out myasthenia. This is also another interesting case. This patient had undergone surgery for cataract 3 months back, first on the left eye. And 1 month later, patient underwent cataract surgery on the right eye. Okay. After removing the patch on the right eye after the second surgery, he noticed diplopia, which is binocular, and more on looking to the left side. Diplopia was having a horizontal and vertical separation. Clear? Is clear to you? Okay. He went back to the ophthalmologist and complained that he had diplopia developing after your surgery, what to do. But he was reassured that this will occur initially after 1 week after the surgery. Don't worry about it. Get over by itself. But since the diplopia did not subside after the specified time, he went back again to the same doctor. The doctor detected that he has got bilateral ptosis and referred to me and ruled out myasthenia. This is the patient. He has got bilateral ptosis, as you can make it. I'll show the video of the patient. But the ptosis was
maximum.
I'm asking to keep on looking up, looking down. Eye closure was okay. Now look at the position. I'm asking to find diplopia. Now, this is the position where he finds maximum diplopia. Looking down, up, it is, he said, less. It is less. It is much less. He says only 1. 1 is slightly blurred. I'm asking it is the maximum diplopia. That's a position where he says the maximum diplopia. But look at the eye in this position. That's a position of the eye. And all other direction, the movements are normal. There was no diplopia. The only finding was a diplopia and looking down onto the left and this side position. So once again. So let us see what are the possibilities. What is causing the diplopia 1? And what is the causing the bilateral ptosis? And what is etiology? Now I'll show let's see the first question, which muscle is weak? Now, this is the position. Diplopia is maximum in this position. Can you see that? Okay, looking down onto the left and look at the eye. This is. Left eye is little up compared to the right eye, or right eye is low compared to the left eye, correct? Do you agree with me? Do you agree with that possibility? I'll show you once again. See, this is the position where his diplopia is maximum. And the disconjugation, what you see is diplopia. The right eye is lower compared to the left eye. Do you agree with that? Okay. So in that case,
left inferior rectus.
Okay. Or
right superior oblique.
Not right superior oblique.
Right, right inferior oblique. Yeah.
Correct. You're perfectly right. That means either it is left inferior rectus where the left eye is not coming down fully, that is why left eye is up, or the right eye is not elevating fully because of the weakness of the right inferior oblique. That is why the right eye has come down. Agreed? So either left inferior oblique, right inferior oblique or left inferior rectus. Any doubt in that? Anyone? Okay, then let us see. Now you find out which one is the culprit. Is the left inferior rectus or right inferior oblique? All common sense questions. Inferior. Why it is your right side? Somebody said inferior rectus. Why not right inferior oblique?
അതൊരു ബെൽസ് പാൽസി എന്ന് ഉറപ്പാണെങ്കിൽ വൈസ്ലോൺ 20 മില്ലിഗ്രാം TDS കഴിച്ചിട്ട് ഒരു 5 ദിവസം കഴിഞ്ഞ് വരാൻ പറയും.
Joy, you can unmute yourself for your mic. Okay.
The diplopia is maximum looking down and to the left side.
Exactly, that's the answer I want. If it had been a right inferior oblique palsy, then the diplopia is maximum looking up and to the left. So it's most likely left inferior rectus. But the problem is that many people, when you see patients, they will confuse you. Sometimes they may say it's the maximum looking left and down. Sometimes they'll feel up and down. This you must have experienced by yourself when you start analyzing vertical diplopia. People will confuse. Sometimes you say it's not there, sometimes it is there, sometimes looking and say it is there. So that question is always there. So we have to have a more objective proof of differentiating the two. So what test will you do to confirm whether it is inferior rectus on the left side, inferior oblique on the right side?
Can we close the eye on one side and check the movement?
No, that will not help because some subtle restriction of movement, the adduction appears normal. If you close one eye and look, it appears all movements appears normal. When you do the conjugate movement only, you find one eye will be up compared to the other.
You can do a head tilt test.
You can what you call the Bielczewski's head rotation test. That is good for oblique muscle paralysis. Let us see. I am doing the head rotation test now. I'm moving towards left side. He says only one. Now with the movers, we deploy phase move. Now it is less. One means. Okay, so on turning to the head towards the left side, there is no diplopia. It is only one. On rotating to the right side, he is seeing double or worsening of the diplopia. So which muscle is weak?
Left inferior rectus.
Okay, very good. So you know the reason why it is so. I'll explain a little bit for people to make understand easily. So later this diplopia and squint is less on lateral helping to the left side. Okay. In this position, what happens is that the left eye intorts and the right eye extorts. You turn your eye to the left side, that eye will intort, right eye, opposite eye will extort. So imagine, suppose this patient's right inferior oblique is the culprit. In this position, normally both extorters of the right eye contract. If inferior oblique is not acting, the extortion is carried out by only other extorter, that's the right inferior rectus. Correct? Turning the head to the left side means the right extorter should extorting. The two extorters are what? Extorters inferior rectus and inferior oblique. Inferior oblique is the presume it is the one. The inferior rectus is the only one extorting the eye. When the inferior rectus contracts, what will happen? during it contracts without the contact on the inferior oblique. So what will happen? Inferior rectus is an eye which pulls the eye further down. So it should have produced the diplopia worse, because if it was right inferior oblique, during extortion is carried out by the inferior rectus on the right side. That will pull the eye much more down, and the diplopia should have been worse in this position if it was the right inferior. Correct? Now, what happened when it was the opposite? Diplopia disappeared in this position. So it is not inferior. That means the culprit muscle is not the right inferior. On the other hand, let us see if inferior rectus is the culprit, what will happen in this position? In this position, the left eye has to indort. But if left eye is affected, nothing is going to happen. Left inferior rectus is not an indorter, it's an extorter. Both indorters, the left eye, the superior oblique and superior rectus are normal. Nothing will happen. The patient will not have any problem. Since left inferior rectus is not put into action, movement which occurs only in the indorser. So this tells you that this is likely to be right inferior oblique is not the culprit. Now let us see, turning the head to this position. In this position is the maximum position of diplopia. In this position, the right eye indorts, left eye extorts. Okay. So in this, if the diplopia is in this position, the problem is should be either one of the indorters of the right eye or one of the extorters of the right eye, of the left eye. The extorter here is either the inferior rectus or inferior oblique. The muscle in question is our left inferior rectus, right inferior oblique. You got the point? See, right eye indorts, left eye extorts. The extorts on left eye are inferior rectus, inferior oblique. Our problem is inferior rectus versus right inferior. On the right eye, indorters are superior oblique and superior rectus. So if it occurs there, here, the question between two is inferior rectus and inferior oblique. Inferior rectus has to be inferior. So otherwise, the other way to explain is that imagine the right oblique, the inferior oblique is the culprit in this question. Nothing will happen because right inferior oblique is not an indorter. What action is taking place in the right eye is an indorser. But an extorter, and the indorser in the right eye is unaffected. Since the left inferior rectus is not affected, normal extortion takes place in the left eye. No worsening of the diplopia. Okay, if it the right inferior oblique is the culprit. Imagine left inferior rectus is the culprit. Normally, both extorters contract in the left eye. There is a left inferior rectus and inferior oblique. Here, left inferior rectus is weak or not acting. The only available muscle to produce extortion is the inferior oblique on the left eye. So, which when it contracts, what happens? It will, inferior oblique when it contracts is an elevator. It makes the eye move further up. Already the left eye is up. It will become more further up, and the disconjugation is more, and with producing version. So that's why I taught you like this is that this is the principle behind the Vitreous head test, why the diplopia is becoming more when you tilt the either direction. Because out of the two indorters or two extorters, one is acting, one is not acting. So the other muscle will act under post producing its vertical action. So now we know the left inferior rectus is the culprit, and the patient needs notice retosis. Now, what is the etiology in this patient? Fatigue is ptosis is not fatigue. Anything else you want to do?
MRI.
MRI, what possibility you had in mind? For third nerve palsy?
Yes.
Nuclear again, bilateral ptosis.
Inferior rectus and bilateral ptosis. You mean
do an impact test or a neostic?
Paramedian nuclear.
Do you think it's likely possibility in this patient? See the sequence, what has happened, involved over a period of time. Okay, yes. You want myasthenia? Okay, we can do myasthenia. Hardness was negative, neostick was negative.
What about ice pack?
Ice pack also negative.
So paramedian nuclear because the superior rectus will be medially placed.
Yeah, but how can you get this? You have to say nuclear third now, no? Producing bilateral ptosis and nuclear rectus on one side. That's a possibility. That cannot totally rule out that. Why should you talk in this patient like that with only no other findings? You know what is happening? I'll tell you. This, in fact, you don't need any test in such way. This is very, very common problem which you come across following cataract surgery. Because this patient had been having a vertical diplopia earlier, which is compensated by a skewed fusional system. I'll make it very clear, not don't worry. Then this is original. Very often you find person with concomitant skin, or there will be a phoria or a latent skin, which are masked by the fusional system. They will not have a diplopia. We all have some degree of skin, but we are correcting it by your fusional virgin system. That for the fusional system to occur, we should have both eyes, we should have binoculars. So this patient, imagine the patient had got a vertical diplopia earlier. Then he developed cataract of both eyes, which might have been more on the left eye because he was operated first on the left eye. So with the loss of vision, what will happen? His compensated squint might have broken down. But he did not develop diplopia since he was having severe vision loss. You got the point. You got a latent squint which became manifest. A manifest latent squint should produce diplopia, but it's not producing diplopia. It is the manifest latent squint is because of loss of vision of one eye, loss of binocular vision, not like a fatigability of the ocular. So following his cataract surgery on the left eye, his vision returned to the left eye, and the diplopia should have manifested at this point. But, however, he was having cataract even on the right eye, which might have prevented him from having diplopia. So, however, after the second cataract surgery on the right eye, his vision returned to both eyes, making his diplopia manifest. So his vision has become normal. So his the original the latent squint which had become manifest because of his loss of vision. Now when the vision is removed, the manifest squint is now there. So he started having experiencing diplopia. So I'll explain in a little more simplified manner. This patient has been having just 1 minute, having a latent squint or phoria, which remained compensated for many years. With the development of defective vision of either eye, the necessity for the vision did not exist, and squint has become now manifest. Original is gone to its original lazy position. Now the phoria has now become tropia. But the patient did not complain of diplopia because one eye was blind before the cataract surgery because of the cataract. With the removal of cataract of both eyes, with the restoration of vision in both eyes, the manifest squint has now produced diplopia, which is likely to, this diplopia will improve over time when the brain recalibrates the new need to have fusion of the images, making the tropia again a one of phoria. Okay, any questions now? Somebody wanted to ask it? Yeah, please.
So what is the cause of previous squint?
What is that? I didn't hear. Please, can you repeat the question?
So what is the cause of the previous squint, sir, before cataract?
No, that he has got a latent squint. Latent squint means phoria. I mean, many of us, you and I are all having some degree of phoria in our eye. So that phoria will not manifest because we are able to correct it by your fusional virgin system. Phoria means latent squint, which on binocular vision will not be seen. You can make it appear only by a cover-uncover test, shifting cover test from one eye to another. Then you find that the one eye will, the eye, or to remove the cover, the eye will come back to the fixing position. Because under cover, the phoria or deviated eye will go into its original lazy, deviated position. But when you look with both eyes, there won't be any disconjugate. It will be normal. That is what is called the latent squint or phoria. In fact, the commonest, I'll repeat it, the commonest cause of an intermittent diplopia is this manifest latent squint. which occurs after prolonged, many people come to diplopia on prolonged reading or prolonged watching television. Now after seeing, nowadays after seeing this mobile phone, continuously watching, they develop diplopia. But they keep the eyes closed for some time, take rest, that will disappear. Because for continued watching, our constant effort to make the fusional virgin system breaks down. It's fatigued. Then deployed. And that's called the manifestation. Okay. Any other question?
Sir, if the both eyes were operated, then why it should have become just like the previous one only? Why then there is
That's exactly, it become just like a previous one. But what happened means that he had been having this latent skin for a long period of time, which is correct. Let us presume he did not, a situation where he did not have any cataract. Normal as per normal vision. So what happened? His latent phoria or latent skin or phoria was corrected by his fusional system. His brain has made it corrected and making it aligned. But for that alignment to occur, or the fusional vergence to occur, we should have binocular vision. If one eye is covered, the other eye will go into lazy position. So both vision should be normal to produce the brain to make it aligned. That has been going on like that. Then he developed the cataract. When one cataract is affected, the one eye is lost, vision has been lost. So his need for the fusional versus the brain is not having any need for a fusional virgin system. The fusional virgin system is for binocular vision. So the eye goes into his original lazy position, deviated. But he did not complain diplopia. Why? Because the eye has become blind. Then he started operating it. Vision become restored. Now what will happen? Already the skin has gone on to its lazy position. Now one fine morning, the brain finds that both vision has come back. But the eye is already gone into the lazy position. So it now started manifesting diplopia. Now the brain has to recalibrate and bring back again his system to make it aligned. That is, the manifest latent skin has now to be bring back to your aligned position by the effort of the brain. This will take some time. Recalibration. You understood, Haki? Have you understood what I said?
Yeah.
only partially only. It's okay.
In fact, sometime back I took a class on diplopia, and there is cover and 3 days back. I think Joy was there when he had a diplopia. I talked about cover and cover test. Doesn't matter. This coming Thursday, they could have the Miliap meeting. In that thing, I'm going to talk about good case on showing this cover and cover test.
Thursday, sir. Okay.
Yeah.
Sir, how to explain ptosis, bilateral ptosis?
This is the next book. The story is not over. You're right. Explain the bilateral non-fatigable ptosis. So again, you look very carefully. Since it is noticed after cataract surgery, it was not there before. It might have been due to the elevated dehiscence, which is the commonest complication of cataract surgery. If you find most of the cataract surgery patients, they come with one ptosis of one side. It's very mild, it goes unnoticed. Here also, it was not this complaint at all. It was only detected by the ophthalmologist as a ptosis. Now, how to prove this point? You have to look for as a patient to bring his old photograph. The old photograph will show that his eyes were not, before cataract surgery, it was not. That tell you that it's related to the cataract surgery, nothing to do with this particular, I don't present there. So this patient had a elevated dehiscence due to cataract surgery and the manifestation due to diplopia. This patient after came, I did nothing, followed up, it became diplopia, gradually became moderate up to. I asked him to do the Virgin's exercise, and then diplopia gradually improved out. Doses remained the same. No treatment was required for this patient. Any questions on this case? In fact, this I think you should know about this. It's one of the common things which come in your OPD. Often people do neostatic. Some people have seen on neoprostatic and gravito tablet for long because of this. Okay, shall I go to the next case?
Yeah.
Time for one more case. Okay. This patient had a known case of diabetes and depression for last 8 years on treatment with Diplopia. This is a really straightforward case. The present complaint started 6 weeks back as impaired working memory, executive dysfunction in the form of mistakes in cooking, inability to identify faces for the last 4 weeks, decreased word output ending in almost mute state for the last 2 weeks, excessive jerky movements of the body, sometimes going on to continuous jerkiness, lasting for 5 to 10 minutes, especially when exposed to light. These are the complaints. Memory issues, especially working memory, frontal lobe dysfunction from executive dysfunction, inability to identify faces, probably prosopagnosia, decreased word output ending in almost mute state, probably in apathetic state, or you can call it as a Broca's aphasia, excessive myoclonic jerks of the body, sometimes going to myoclonic status, which is light sensitive. I'll show the video of the patient. The frightened look of this patient. Asking her name, she could manage to tell her name after a period of time. She said, I asked him who is standing in front of her. She could not identify her. She could not identify by face, but recognized the person. She is able to see the nose, able to see the fingers. See the light-induced myoclonus. Motor state examination was for severe rigidity of both upper and lower limb. It is more on the left side compared to the right.
ഒന്ന് മുറുക്കി പിടിച്ചേ എൻ്റെ കൈ ഇത് മുറുക്കി പിടിച്ചേ ഇതൊന്ന് മുറുക്കി പിടിച്ചേ പിടിച്ചോ അമ്മ പിടിച്ചോ കൈ മുറുക്കി പിടിച്ചേ മുറുക്കി പിടിച്ചേ മുറുക്കി പിടിക്കേ മുറുക്കി പിടിച്ചേ അമ്മ എൻ്റെ വിരൽ
Become sometimes the dystonic portion of the hand out. Was in a repeated continuous for a period of time. Then he's got a plantar grasp. When you do the plantar response, foot goes into plantar grasp. Means like this is the plantar grasp. In one of the primitive reflexes, when the grasp goes into the he cannot stand, only can stand with the support of the and if making her walk makes it a short gait. The moment of this will fall down. Severe postal impact. This is after the during after admission to the ward, when I could not examine properly in the OPD. You can see the dystonic posturing, severe rigidity in the lower limb. Difficult exam reflex because it keeps it rigid, and the foot goes into plantar grasp. So, what all things did you observe? Frightened, staring look, severe decrease in the word output, and patient only mumbles, prosopagnosia, dystonic posturing of both upper limbs and feet, more on the left side. Severe rigidity of both upper and lower limbs, again more on the left side. Myoclonus, stimulus induced, occasionally going into myoclonic status. And severe gait initiation difficulty and postural instability. So, what is the likely diagnosis in this patient? 6 weeks duration.
CJD.
So what is the drug she was on, sir?
She was not, I don't remember, she was given some lithium, she was having diabetes and depression. What I remember was that lithium she was on lithium and some other antipsychotic, I forgot.
She's on clozapine.
Pardon?
Clozapine. You said she was on clozapine.
No, lithium and some antidepressant. Not possible, lithium. Okay, the possibilities concern subacute encephalitis like CJD, Hashimoto's, or other autoimmune encephalitis. So, what investigation you require now? Anyone can voice out? Anyone? Okay, MRI works. MRI show this the player sequence. Pardon? Yeah, I'll show you. It's the MRI of the brain. Player sequence normal. Antithyroglobulin antibody normal. Blood chemistry normal. Autoimmune antibody panel no antibodies detected. CS was normal. Anything else you want now?
EEG.
EEG. Okay. Is a EEG. EEG typical of say 1 per second sharp discharges in a periodic fashion as they will see it. Now, look at the MRI of the patient. Always you may miss findings in the conventional MRI unless you do diffusion sequencing. The diffusion weighted sequencing, you can find the cortical ribbon sign. Here, 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 and now. Especially the parieto-occipital region, that is the patient had prosopagnosia. Again, you can find out the diffusion restriction posterior and also the cingulate cortex anterior. There is a maximum on the right side. So it's a case of CJD. Okay. There is a straightforward case to show you that sometimes you can go into myoclonic status like this. So should we stop or go for one more case? Any questions in this case?
The management of the case, sir.
Management, I could not end with the patient. Ultimately, I sent the patient home. What to do? We tried many things, nothing worked. I gave a course of for anything, tried major prednisolone. Suppose it's some kind of an autoimmune encephalitis. Like a VJ case, which is did not produce improvement. Okay. Shall I stop? Or one more case?
One more case.
Okay, one more case. One good short case, okay? Practically oriented case. The 60-year-old person is a non-diabetic, had presented with complaint of walking difficulty in the form of inability to propel his left lower limb forward for the last 1 year. He said he had to put some extra effort to put them forward. He also gave history of numbness of both feet for the last 1 year. Now, this is the video depiction. Or normal.
ചവിട്ടിക്ക് ബ്രേക്ക് ചവിട്ടുന്ന പോലെ അതെ ഇതിൻ്റെ ചവിട്ടിക്ക് ശരി ഇത് വെറുതെ മടക്കിക്ക് ഇത് മടക്കിക്ക് ദാറ്റ്സ് ഫൈൻ ഡയബറ്റീസ് തുടങ്ങി എത്ര വർഷമായി 16 വർഷം.
Is diabetic velocity. Nervous flexor. Yes, hypostatic.
ഇങ്ങനെ കുത്തി വരുമ്പോഴേ വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയണം. ഒരേപോലെയാണോ? ഓൾമോസ്റ്റ് സെയിം ആണെങ്കിൽ വിട്ടേക്കാം.
We did not say level for the pain. Almost same is it. But it invade vibration and joints and so both.
കാല് പൊക്കിക്കുമ്പോൾ
look at the gait of the patient. This is how he is walking. I'll show you one. Okay. Now his gait, I don't know what to call that gait. Some problem with the gait. Okay. Deeper absent ankles and sensory dulling on both feet. Okay, what do you want now? Positive findings were his power appeared normal. Anal jacks are absent, distal impairment, the posterior column and vibration. Thrombus was negative, however, and he's got walking difficulty like this. What do you think the possibility this patient or what investigation like to do? Anyone, please? Anyone can voice out, please. Okay. So conduction was done. This MF amplitude. Am I audible or not? Am I audible?
Yes, sir. Yes, sir. You are audible.
Okay. So right peroneal, this is amplitude of CMAP amplitude, right peroneal, right tibial, left peroneus, and right tibial. So all decreased, more so on the left tibial. But all are CMAP amplitude decreased. Velocity is normal. Here the FAV is prolonged, much more prolonged in the left tibial compared to the right side, compared to the other side. And all sensory potentials are absent. So what is the diagnosis now? Is it diabetic peripheral neuropathy causing his walking difficulty?
So what about the sphincter involvement? Any?
Okay. About that, but I did not hear you.
Sphincters.
Sphincters.
Bladder.
Not affected, not affected, not affected. It's only complaint was these times a walking difficulty. As if he has to put extra weight on the left leg. That's his complaint.
Nerve connection of upper limbs.
Connection of upper limb was normal. Anything else? Okay. Could it be a radiculopathy by any means?
Yes.
Sensory potentials are absent, but he has got to say already peripheral neuropathy is there. But over and above that, could it be a radiculopathy? Very difficult to diagnose a radiculopathy in the presence of peripheral neuropathy, but there is no weakness to suspect radiculopathy. So, what do you like to see in this patient? Let us see. Minor radiculopathy. Ventral hip abduction weak. There is one reason why I did do this test. I will tell you later. Over this negative. Okay. Now, I want you to look at the gait once again in this patient. Look at the gate once again. Anything else you found? Did you think the knee was more flexing than normally?
When spastic component.
Let us see. The knee gets flexed while walking. Okay, so what will you do in this patient? tell you what I did. You ask the patient stand on heel and toe. He's able to stand on heel very well, but he cannot stand on toes. He has and I cannot stand on toes. Instead, the knee flexes. So what does it tell you? This I shown last time itself. His plantar flexors are more weak than the dorsal flexors. Manual twisting at the bedside, it may appear normal, but always make the patient to make stand on heel or toes, ask him get up and squatting position, or for hip abduction through the turning back test. Otherwise, you will miss weakness of that particular muscle. He respected weakness, he abducted, but it is not there. But plantar was grossly weak. He cannot stand on his toes at all. So, what does it tell you? It is not due to the peripheral neuropathy. Peripheral will not produce weakness of plantar flexors more than the dorsal flexors. Never. Always dorsal flexors are more affected than the plantar. When plantar flexor weakness more than the dorsal flexors, this has to be either in the tibial nerve or more commonly in the right foot, radiculopathy, S1 radiculopathy. Or rarely it can also occur with some kind of a myopathy. That's a different issue. Myopathy. So this is more likely to be radiculopathy. So what association with an MRI investigation. There are a significant dysplasia at L4, L5. He was operated, his plantar flexor weakness improved almost all. Okay, any questions in this case? The lesson is that always make the patient to stand on heel and walk. Otherwise, you will miss in suspected so-called some walking difficulty, even if you are not make out grossly what the gait abnormality was.
But there's no significant low back pain.
Nothing. That is how neurology cases present. They don't present with the classical picture at all. It all depends upon the disc prolapse, which roots it compresses. Predominantly motor roots, it produces only motor weakness. Sensory may not be there. Because the motor roots and sensory roots are separate in syntacodic. If it is central disc prolapse, it may even compress only the motor root. Anterior compression. Any other questions? Okay, shall we call it a day?
Yes, sir. Thank you. Thank you, sir.
Thank you. Thank you. അവസാനത്തെ കേസിൽ ജോയുടെ ഒന്നും കമന്റ് വന്നില്ല. ജോയ്. Okay. See you next week.
Thank you, sir.
Thank you.